We'll
Yes,
start. Yeah.
thank
Yeah.
you.
Okay.
Good afternoon, doctors.
Good afternoon.
Welcome to you on this webinar on influenza and its prevention from Heathrow. Heathrow Healthcare, as you all know, is an innovative pharmaceutical company. We have presence in 30 years of excellence. We have 36 state-of-art manufacturing facilities, 300 plus products in our portfolio, presence in 126 plus countries. We have 21,000 global employees globally, and we are amongst the largest manufacturers of ARV, APIs, FDFs in the world. Heathrow Healthcare is 360-degree solution provider striving to fulfill unmet healthcare needs, reaching to customers across India with wide range of products encompassing multiple specialties, pioneering in quality and innovation, and we have the distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. Heathrow Healthcare, the pioneer in antiviral during COVID time, offered favipiravir, oseltamivir, and remdesivir for care of COVID patients, for which the company received award for COVID drugs in August 2020, award of pharma excellence in August 2020. Now we all know that influenza has got its own complications, and influenza can affect life, especially in children. And we know the requirement of prevention. Although there are many papers to this extent, we always like to have our own doctors' insights on this. For which today we have got Dr. Mahendra Patel and Dr. Murlidhar Mahajan. Welcome, Dr. Patel. Welcome, Dr. Mahajan, to this webinar. Dr. Mahendra Patel is MBBS MD DCH, sir, is senior pediatrician from Goregaon, Mumbai. He's in practice for past 30 years and he did his MBBS from prestigious ZGS Medical College and KM Hospital and MD from LTMMC Science. Sir holds diploma in mother and child health and he has done certificate courses in pediatric asthma, pediatric neurology, pediatric intensive care, and pediatric nutrition. He has been associated with various IIP and IME activities and has long been associated with Goregaon Medical Association and was the past president of Goregaon Medical Association. Welcome, sir. Dr. Murlidhar Mahajan is MBBS from GS Medical College, MD DCH from JJ, and DNB from Board of Examination Delhi. Sir is MNAMS Postgraduate Program Pediatric Nutrition, consultant in Jupiter Multispecialty Thane, has presented more than 150 papers at national and international levels, has delivered more than 200 talks at various CMEZ conferences, has been organizing secretary for Mahapedicon, Epicon, and KMACon. Sir has conducted webinars which is attended by PG doctors, nurses, and pediatricians on various topics like vaccinology, immunology, infectious disease, breastfeeding, nutrition, skincare, etc. Welcome, Dr. Murlidhar Mahajan, and over to you for the session. Well, over to you, Dr. Mahendra, for the session.
Yeah, can you hear me?
Sir, we can.
Yes. Mahendra bhai, we can hear.
We can.
Yes,
Yeah,
Mahendra.
Murli, slowly we'll become experts in flu and oseltamivir.
बराबर है correct है.
Uh-huh.
Good ना, we are at least expert in few topics which are
नहीं
currently trending topics.
नहीं वो बहाने क्या है, थोड़ा पढ़ना हो जाता है.
And most of this viral epidemiology also we come to know, because we are reading again and again. Good.
Yeah.
So we'll start, Mahendra bhai.
Sir, this
Yeah.
is typical of GS Medical College. Studying because I come from JMC.
Yes.
Okay.
Sir, you are on mute.
Yeah, can you hear me now?
Yes, we can hear you.
Sir.
We can hear you.
Yes, sir. We can see the
Yes,
slides
Mahendra.
also clearly. Yes.
Yeah.
Okay. Well, good afternoon, friends. On a Thursday afternoon, we'd like to share some insights on flu and its management. And I would like to thank the company for arranging this. And friends, this is a sharing of knowledge and brushing up on what we already know and share our experiences. Now, why flu? When the Chinese virus nowadays is going on metapneumovirus and mycoplasma is in the air, so why flu? The importance is that flu is and remains a very important disease burden, particularly during the winter months, that is December, Jan, Feb. So our focus should not be distracted towards the Chinese virus going on. Flu remains our main priority. And the disease burden of flu is every year in every state and every part of the world, sort of. We'll cover certain aspects of flu, the epidemiology, its signs, symptoms, the complications, and then we'll move on to the important drug which is there, this oseltamivir, and certain guidelines for the use of oseltamivir, including doses and prophylactic treatment and certain case studies. Vaccine will not touch upon much because the time is limited. So just a brief view on the vaccine, but will not touch on this particular topic. Yeah. Now, when we say flu, commonly we call it as flu, it's an influenza virus. Now, we should remember that it is not only a respiratory tract infection, predominantly respiratory, but from head to toe, it can affect each and every part of the body. So it causes a lot of morbidity and mortality. Now, regarding the different types of flu virus which are there, A, B, C, and there is D also. As we have studied in our microbiology days, it belongs to the group of orthomyxoviridae. And it's a single-stranded RNA virus, enveloped virus, and there are 8 RNA strands are there. Now the classification is there, the A, B, C, and D. Now our focus will be A and B because these are the ones which we commonly encountered, while as the C and D are not much. Regarding the D virus, just we should remember that it is mostly among the cattle. It can infect various type of cattle, including horse, camel, deer. So it's more in the animal kingdom, not much of importance in human beings. But as we know, anytime this type of virus can cross over, and maybe in future, it might be a big problem. Regarding the C virus, which infects human and swine, the C virus is usually a mild respiratory illness and doesn't cause much of an epidemic. But the importance regarding C is, in fact, we don't have much of testing facility for the C virus. So the commonly testing facility are A and B, and C is somehow missed because it's difficult to diagnose and the testing facilities are not adequate. But in a study, it has been found out regarding the C virus that almost by the age of 10 years, almost 70 to 80% of children have been infected by the C virus. And this is particularly common in the first few years of life, that is first 3 years of life. But since it is a very mild disease, it is not very important, but some cases of pneumonia do occur with influenza C virus. Now, what we are major concerned is regarding the A virus and the B virus. The A virus is a very important cause of epidemics and sometimes pandemics. Comparatively, B virus, it's a slightly milder virus and it causes some local epidemics. Now, certain regarding the epidemiology of the flu virus, it has a tendency of causing epidemics, that is particularly the A virus. Until date, some of you must have heard in 1918, there was a severe epidemic all over the world, and almost 5 crore, 50 million people had died during the epidemic. And it started in Spain region, and so commonly it is also called as the Spanish flu. So 5 crore deaths, imagine, in 1918. And the second and the third epidemic was in 1957 and 1968. And the fourth one recently, that is 209, 210, as we know, the swine flu virus, which started in Southeast Asia, China and Singapore, Korea. So this A type, we should be wary of causing epidemics. Cases are very enormous cases. OPD cases are also run in millions, and this infection is all over the world. The only thing, the relief factor is that majority are not so serious. And the worldwide deaths, if you see, according to studies, it's almost 2 to 3 lakh deaths every year due to this influenza virus. Regarding the structure of the influenza virus, as we said, it's an RNA virus. And if you see the structure, this flowery structure, it has certain spikes on it, the purple spikes and the yellow spikes. These are very important. The purple spikes are the heme agglutinin antigen, and the yellow spikes which are there are the neuraminidase. So in short, we'll call this heme agglutinin, that is purple, as H antigens, and the yellow ones will call as N antigens, that's the neuraminidase. These are present on the outer cover, and inside there is the lipid, and there is 8 RNA strands. This light blue double parallel line are called as the ion channels, the M2 ion channels, and this is important in the replication process. Now, something about this H and the N antigens, and this determines the antigenic properties of the virus. And the H are almost 18 in number, and the N antigens are about 9 in number. So each virus has a combination of this H and N, and depending upon that, the nomenclature comes. For example, when we say H1N1, that is the common swine flu, it means the first number 1 type of H, and the neuraminidase is 1 type. The other examples are H3N2, that is the third type of H and second type of N. So just imagine, with 18 types of H and 9 types of neuraminidase, so many permutations and combinations are possible. But the good thing about is this, most of this H and N are predominantly in the animals. So the crossover is not there in the human beings, and humans are not a good host. So we are spared. But maybe in future, if the crossover takes and some novel virus comes up, then we have a epidemic proportion of infections. In the human beings, as the slide suggests, the types of H are 1, 2, 3, 5, 7, and 9. There is usually 6 types, and the neuraminidase are type 1 and 2. One thing we should remember is that usually this H and the N types are mostly for the A viruses, while as the B viruses, usually the H and N are not much. So the nomenclature are for the A viruses, which undergoes lot of mutations throughout the year. And the B type are usually the subtypes. Two types are propagating nowadays, which are the Victoria and the Yamagata lineage. Now, certain thing about the A virus is that constant evolution, that is Darwin's theory. So the virus are also smart creatures. They want to undergo evaluation and to safeguard themselves. So throughout the year, certain small variations keep on going so that it survives. These small variations which go on in the antigenic properties is called as the antigenic shift, while a certain major changes are called as the antigenic drift. So remember these words is antigenic drift and antigenic shift. Suffice to remember is that when we say antigenic drift, it means it's a minor change and it may cause certain local infections or local epidemics. And when we say the antigenic shift mechanism, we should simply remember that it is a major change. And this antigenic shift occurs when either 3 or 4 viruses infect the host at the same time, or a novel virus, that is something like a swine or poultry or anything from the animals, they come and infect the human beings and undergo mutation and form a novel virus. And this shift is responsible for epidemics. So this we should remember. Now, certain the life cycle, if you see, will not go into the details of the life cycle, but if you see the virus, it goes and attaches to the host cell. The certain spike proteins which we have discussed earlier, the H is responsible for attachment to the host cell, while as the N, that is the neuraminidase, is responsible for exiting. So for our purpose, we should remember that is H is for entry into the host cell, while as the N spike is for exiting. So briefly, it's similar to all the virus replication processes. Is enters the cell, and once they enter the cells through the M2 channels which are there, because of the acidic pH, there is uncoupling of the protein cover and the lipid cover, and inside the cell there is replication by using the material of the host cell. and then the exit with the help of the neuraminidase. Now, regarding the pathogenesis, we should remember it has a predilection for the respiratory system, and it goes into the nasal mucosa, and there is proliferation in the nasal mucosa and the pharynx, and it has a particular predilection for the sinuses and in the middle ear. So this is an important cause of acute otitis media. When we say the bacteria are important, but this is also an important cause. And it goes into the respiratory system. And as we know, the respiratory system contains ciliary columnar epithelium, and it affects the CC epithelium. It damages the epithelium, and because of this damage, there is a tendency towards secondary bacterial infection. The other thing is the mucus production is also affected. It goes down, and the neuraminidase, that is the N antigen, is important for spreading. It causes the decreased production of the mucus. Now, the incubation period is about 2 to 4 days, and the infectivity is about 1 day prior to the infection and up to 7 days after the infection. This slide is in short as we described the process of infection. Will not go much into the details. But the last few lines are important. The neuraminidase cleaves with the sialic acid residues and allowing the virus to exit. And the digestion of the neuraminic acid in the respiratory mucus, thus facilitating the spread of the virus and giving rise to secondary bacterial infections. There are certain few basic differences between the common cold and the flu. The common cold, as we see, the fever is not much, and it affects mostly the upper respiratory tract, running nose, and throat irritation. And the general aches and pain are usually less. The sore throat is common, mild fatigue, the exhaustion is not much. While as the flu, we should remember is that it causes very high grade fever, something like as we experienced during the dengue season. It causes a lot of headache, body ache, severe sore throat, and severe fatigue, and a dry cough. So this malaise and the pains and aches are very much. And many times this fatigue lasts for many, many days, and the weakness may last for about 2 to 3 weeks also. The only thing we should remember here is in cases of H1N1, which started in 2009 epidemic, the GI symptoms, that
अमेरिकन
is,
नवा नवा होता जाए 4-5 वर्ष नहीं सब दिन जाता जाए
can somebody mute? Somebody is talking. H1N1 epidemic, which came in 2009, we should remember it was a lot of GI symptoms. That is vomiting, diarrhea. So that is the certain hallmark of H1. Now the dangerous part of this is the flu viruses, that is the avian flu, that is H5N1 and H7 N9, which we call avian flu or the bird flu. These are the ones which are slightly dangerous as compared to the other ones. Now the antibody production starts within a week, and the IgA secretory antibodies are produced, and interferons are also produced by the human body, and it gives protection. So the antibody levels are detected after 5 to 7 days. The spread of the infection is usually a droplet infection more than 5 micromillimeter, and while talking, coughing, sneezing, any addition, fomite transmission also important. So you should have good hygiene precautions, just like in COVID. When the COVID had gone, we had forgotten about all hygiene measures, but this particular season, we should protect ourselves. The infectivity period is up to 7 days after the onset of the infection. Only thing we should remember is that in children, the infectivity period may be longer, up to 2 weeks also. And particularly in case of immunocompromised person, due to any reason, the spread of the virus can be longer. As we said, causes lot number of deaths. Now the season is usually July and August in our area, and December to February. So this is the season for flu. How to diagnose the flu? Majority is a clinical diagnosis, and we should remember many other viruses which are circulating during this period, mostly the respiratory ones such as the RSV, rhino, etino, parainfluenza virus, nowadays the metapneumovirus, and the other ones such as mycoplasma, chlamydia. More or less the symptoms are the same. This is a brief differentiation as compared to the others such as the influenza-like viruses and the COVID-19. As we have discussed, most important we should remember that severe headache, body ache, severe myalgia. Now regarding the complications, briefly, we should remember that it can cause multiple complications from head to toe. But the fortunate part is that we do not see much of these complications, but we should be aware of these complications, such as CNS complications, encephalopathy, encephalitis, and nowadays we are hearing of Guillain-Barré syndrome due to certain viruses. So Guillain-Barré is also a possibility in cases of flu and myelitis. It can cause cardiac complications, cardiomyopathy, sepsis, multi-organ failure, but predominantly respiratory, that is secondary bacterial infection. It can cause pneumonia, respiratory failure, acute otitis media, severe sinusitis. So these are the ones we should be aware. Now regarding the laboratory diagnosis, mostly as we all know, RT-PCR, reverse transcriptase PCR, polymerase chain reaction, is the gold standard for the diagnosis of flu. The other tests which are available, which we commonly do, many of us may be doing, the rapid test. The rapid test detects the antigen But one thing we should remember is that it has got less sensitivity. The sensitivity is hardly 50%. So many false negative reports are available because of the rapid test. So clinically, if the suspicion is very high, even though the rapid test is negative, the treatment should be started and it should be confirmed with RT-PCR. The other antigen detection tests which are available is the immunofluorescence test, but the gold standard is RT-PCR. In our setup, it's a slightly costly test, but particularly in high-risk group admitted patients, ICU patients, we should send for this RT-PCR and the results usually are available on the same day. The other tests which are available is the virus culture, but mostly it's for academic purposes and for knowing the strains which are circulating in the community and also for the antibiotic resistance. Now we'll move on to certain case scenarios and then we'll come on to oseltamivir. Dr. Murli,
Thank you. Yeah, yeah. Yes, yes.
yeah, you can
I'm
move to
listening.
this and then we can take things on oseltamivir.
Yes, 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 yes.
Yeah. Exit.
Thank you, Mahendra bhai. Thank you, Mahendra bhai. Can we have my slide, please?
Anybody wants to comment or share experience or ask anything, you can ask.
Yeah. Thank you, Mahendra bhai, for his very elaborative and almost a complete accountability of presentation of influenza in children. Uh, we have taken take-home messages from Dr. Mahendra Patel, which I will continue for in my presentation. One is this swine flu or influenza illness is so rampantly seen nowadays in the OPD. With we can see so many cases clinically seeing every day, day in out, with severe headache, myalgia, extremely high fever, and Dr. Mahendra has very nicely elaborated. One thing is dry cough. He has very nicely said that dry cough is such a common thing. Many times these children present to us with cough which is not going down only with lot of antitussive syrup, lot of expectorant, the cough doesn't go down. Second thing which is very importantly said about myalgia, body ache, severe presentation which is there in these children, which is classically fitting into influenza or influenza like illness. One more thing which is nicely elaborated is GI presentation. He has very importantly said that we are getting a lot of cases now in the OPD coming to us with vomiting, symptoms of gastroenteritis, and then further complication. And since he has also mentioned that in Pune they are seeing epidemic of GBS or paresthesias, paralysis, paraplegia, and all that illnesses. Initially, they can be attributed, thought to be something like electrolyte disturbances, but however, they have been proved to be GBS. And we know that H1N1 is a single stranded RNA virus with antigens of H and N. He has very nicely mentioned H is for entry and N is for exit. Today, the cases which we see, all of us we see in OPD practice, I'm just going to take and share with them. One more point which he has mentioned about the incubation period of the virus, which is very short. Infectivity is pretty long. And this definitely it spreads very fast in the school, babysitting, playgroup, nurseries, and various places. A 13-month old child who presented to me in the OPD with complaint of cough, cold, and persistent fever for 5 days. Uh, Whatever we had discussed by Dr. Patel, cough which is absolutely barking, continuous, not responding to any cough syrups, and fever which is very high grade. He has very categorically mentioned that a common flu will not have such a high fever. Fever is very, very high, something which is in dengue, chikungunya. But we know that, of course, now there is a dengue season or chikungunya season is not going on. But if the parents complain very high fever, severe body ache, malaise, cough which is not getting down with cough suppressant, should make us think about uh, H1N1. This child, because of the fever, went to 2 or 3 doctors, started with antibiotics, cough syrup, breathlessness was present on admission. Child was sick on consulting. There is no history of any cardiac disease. Child was febrile, toxic, 102 of heart rate and 60 of respiratory rate. Wheezes and cramps were present. And he was thought to label as child chest suggestive of a bilateral diffuse haziness. So we know that whenever we encounter a bilateral disease, it is more likely to be viral over to bacterial, because we know that by now we know that bacterial infections take time to spread, usually are localized or compartmentalized, commonly in the lobular pneumonia. If the child is feeding when the lying down position, then upper zone pneumonia. Sometimes they aspirate, then right or left lower zone pneumonia. These are very common particular presentation. HIB, Haemophilus influenza B, again affects particular lobes. Pneumococcal pneumonia again affects left side more to the right side. But if you see bilateral and diffuse, it categorically mention either it is mycoplasma pneumonia, viral pneumonia, something like H1N1, or a different kind of viral infection. Next, please. So our impression was this child was a classical case of lower respiratory infection, being bilateral in etiology, looks more likely a viral with dehydration. He was started on antibiotics, IV fluids were given. Before being admitted to hospital, he has received a set of antibiotic. Again, once he got admitted, he was received another set of antibiotics and IV fluids were given. But somehow, next please. Yeah, this is a classical presentation, suggest of hilar, parahilar presentation with bilateral infiltrations, which is seen in these cases, which is classically seen in case of viral pneumonias. Next one, please. So this child was put on to various antibiotics, amoxiclavulinic acid, ceftriaxone, but somehow he was not responding. The fever was not coming down. The cough was persistent. He was not responding to nebulizer, bronchodilators, and here in the came the role of fluvid or oseltamivir. And moment he started on oseltamivir, the child becomes symptom free within 24 to 48 hours. Slowly the cough and breathlessness decreased, the fever came down, and the child improved clinically and was also discharged. Next, please. So, as we know, as Dr. Mahendra Patel has said, epidemiology of respiratory infection, we get to see these peaks of influenza in August, July, and then another peak in something like January, February, partly in December also because of change of weather. And many times we know that July and August are the timing wherein even dengue, chikungunya is also seen. So most of the time we are doing test for dengue NS1, dengue antibodies, chikungunya also. But probably we are not really very keen to do test for H1N1. And as Mahendra Bhai has very rightly said, this H1N1 test are basically the real-time PCR, which are definitely costly. Parents are not affording or not keen to do. The rapid antigen tests are absolutely not so reliable, only 50% specificity and sensitivity. So the need of our is just to clinically suspect H1N1 or influenza like illness in these cases amidst the pool of dengue and chikungunya in July, August. But fortunately, what happens in December, January, February, the dengue and chikungunya cases have gone down. So that is a time we are only looking at influenza or illnesses coming out of influenza. Like we have seen the recent epidemic of GBS along with gastrointestinal infection is labeled to be as because of influenza illness. So epidemiology is very critical in analyzing these cases, and it is very partly and definitely helpful and coming to conclusion and treating these cases. Next, please. And as rightly been covered, the respiratory infection affects sinus, throat, and even ears. Apart from bacterial infection, even viral sinusitis, viral pharyngitis, viral otitis is not uncommon. Even those cases also we see very commonly. And this mostly caused by viruses, sometimes by bacteria. And so it is very hard to differentiate between a viral and bacterial infection if they're involving otitis media, rhinitis, and pharyngitis, except that you may get sometimes tonsillar infection or pus. However, a clinical judgment or a clinical indication to see that it is viral is very important for prevention and treatment because in these cases especially we require antiviral agent. Next, please. So a respiratory infection we know is divided into two parts. One is upper respiratory infection and a lower respiratory infection. We know that upper respiratory infection involves nose, throat up to trachea, while a lower respiratory tract starts from trachea to bronchi, bronchioles, and to alveoli and pleural areas. So, upper and lower respiratory involvement is quite common in viral infection. That's why we see many times in H1N1, the child will have continuous coughing because of pharyngitis or upper respiratory involvement. And slowly, as the disease progresses down to lower respiratory tract, they start with breathlessness, wheezing, crepitations. So, definitely looking at anatomical diagnosis of viral infection is very crucial in eliminating the other causes of bacterial etiology. Next, please. So, a child who is coming with breathlessness, with crepitation and wheezes, we know that it is a bilateral disease. So, looks like more of a bronchiolitis, bronchitis, or viral involvement. A child coming with blocked nose, severe cough, throat congestion, headache because of sinusitis is classically upper respiratory etiology. So, clinically in a OPD, coming the child, we have to analyze whether it is upper respiratory airway disease, a lower respiratory airway disease, or combined or both. And depending on this, we have a particular diagnosis been established in these cases. Next, please. So here comes the role, as Dr. Mahendra Patel has very rightly said, that the virus has beautifully two antigen, was hemagglutinin and second one is neuraminidase. Hemagglutinin is important for attachment of virus to the host cell, while neuraminidase is important for attachment to sialic acid, multiplication, and exit from the cell. So each one of them has an important function. H is for entry, N is for exit. Next one. These are the doses which are recommended for oseltamivir because we know that in these cases we want the virus not to replicate fast. So we are using a drug which is called as oseltamivir, which is neuroaminidase inhibitor. There have been a lot of antiviral drugs which have been launched in the past. Of them, the safest and really very effective has been oseltamivir. In my clinical practice, as Dr. Mahendra will also agree, that many of these cases who come to us with severe gastroenteritis, very high fever, no dengue, chikungunya, looks H1N1, even those children, if they present to us even on third and fourth day, we do start them on oseltamivir. Ideally, we know that we should start this treatment within 24 to 48 hours because he has rightly said the incubation period is 24 to 48 hours. If you start during this time, because it is a neuroamidase inhibitor, it will prevent replication of the virus and spread of the virus within the host and also in the society, also in this in his household and to various children if this child is going to the school. So how do we give oseltamivir? Oseltamivir dose is very nicely mentioned. Uh, Less than 15 kg of body weight, we give them 30 mg 2 times a day. So it is a 60. Then 15 to 23, it is 90. Then 23 to 40, it is 120 mg per day. And more than 40, it is 180 mg per day. And the prophylaxis dose is half. If it is less than 15 kg, it is 30 milligram, but the duration is 10 days. So the treatment is 5 days, and prophylaxis is in the household contact or the children or those adults who come in the case of positive H1N1 can be started with a half daily dose of oseltamivir for 10 days. So this is very important chart for our day-to-day clinical practice. And as Dr. Mahendra has very nicely mentioned, it is 60, 90, 120, 180. So it is his favorite formula, which we should never forget. Next, please. Yeah. So respiratory infection, the infection which Dr. Mahendra Bhai has already covered, COVID, normal respiratory infection, and others one. But you are looking at various like sometimes like whooping cough. Uh, though so not so common, but actually it is will come with dry cough. Fever is not so very high in these cases. Croup, very classically seen as upper airway obstruction. The history is very classical. The child ate something, or there is some allergic response to some particular food, and sudden episode of choking, breathlessness. The child is not able to breathe, becomes very restless in the OPD, and we diagnose them as croup. Ideal treatment is dexamethasone. While in case of H1N1, we don't give dexamethasone unless until the child is distressed. The ideal treatment is antiviral, that is oseltamivir. We don't give any steroid. But in case of croup, the ideal treatment is steroid or racemic epinephrine. RSV, another viral involvement in which bilateral chest congestion is seen, and again the treatment is symptomatic, nebulizer. And many times, what I heard see, or all of us will share in the OPD that a viral etiology of any of these conditions, we assume it to be influenza or H1N1, probably initial in the initial phase, and we start them on oseltamivir, and somehow some of them will respond beautifully, even if they come present late or they come with very high fever, prostration, or even GI symptoms. Next, please. Next, please. Ideally, diagnosis in case of H1N1 involves collection of nasopharyngeal swab or oral throat swab. This has to be meticulously collected and to be transmitted in the lab immediately for better culture and growth of organisms and to pick up the antigen H1N1 for RT-PCR. Next, please. Let us look at one more condition on one more case. 7-year-old child who presented to us with chronic cough for 21 days. Multiple set of antibiotics. This is not so uncommon in our OPD that the child is coughing for a long time. Commonly, we label them as asthma, bronchitis, allergic bronchitis. Sometimes, rarely GER in these children who can come with this thing. 7-year-old is little bigger time. He also received multiple set of antibiotics. CBC shows lymphocytosis. IG is normal, so it was not going towards any allergic condition. X-ray chest was normal impression. So again, this was a classical case of viral cough, which went on for 21 days. Uh, and again, he was started on oseltamivir, and he beautifully responded within a very short period of time. So basically, if you keep on changing antibiotics 2 to 3 times in a properly calculated dose of antibiotics, if you use it twice, it is better to change the diagnosis 3 times, third time, rather than changing the antibiotics. Because most of the time, the antibiotic should respond if the child has proper bacterial infection within first 20, 48 hours. If it is not responding, always consider a parallel diagnosis. Or as Dr. Mahendra has very nicely said, if you see a child in OPD who has severe headache, body ache, severe malaise, dry cough which is persistent, child is looking toxic, but not because of bacterial infection or dengue, look at possibility of H1N1. And as we know that type A H1N1 is very common because it spreads very fast. Type B is localized and mild. The strains don't change so much. So H1N1 type A influenza illness is very common and we do see epidemics because of that. Next, please. Next, please. So, yeah. Thank you, Mahendra bhai. So, bottom line is that when we get to see in OPD a classical viral infection because of undetermined etiology, but however, classically clinical presentation, always look at the possibility of early use of oseltamivir. This medication is really very well tolerated, uh, used abundantly in our OPD practice, has a good uh, value added service, meaning it has really been seen in a trial basis that it does well. So overall, I would say that antiviral are one of the key or mainstay of therapy in most of our viral infection and day-to-day etiology. Those should be started within 24 to 48 hours of clinical presentation. Sometimes you do get late, but it is always better late than sorry. Mahendra bhai, you have anything to guide us on this topic
Yeah,
furthermore?
just
Yeah.
last few slides on the
Ah,
treatment part.
ah.
I'll just share my slides.
Yeah, yeah.
Dr. Murli has nicely covered the treatment part,
Huh.
and in his soft spoken but very effective way, he has conveyed the importance of early management, suspicion, and most important, do not wait for the results of the investigation. Clinical suspicion is very important.
Very important.
Just
Yeah.
last few slides on the treatment part I'll share.
Yes, yes.
Mute. Hello, you can hear me?
Yes, yes, yes.
Yes,
We
sir.
can
Yes,
hear
sir.
you.
We can hear
Yes,
you.
yes.
Yeah, yeah. Now, just on the oseltamivir, as Dr. Murli has already mentioned, it's a neuraminidase inhibitor. Now, most important, we have a vaccine available. So, why the drug? Friends, we should remember that vaccine efficacy is 40 to 60% only. And mostly, again, in the older age group, the vaccine efficacy keeps on dropping. So the drug therapy is very important. One is for the treatment part and the prophylaxis part. Chemoprophylaxis is an important aspect. Many times we don't pay much of an importance. Now, just just few lines on oseltamivir, just some we can say tidbits. We have to thank the Chinese for this. It was originally discovered, I mean, made in China from a plant. It's called as NSA plant or also called as a Chinese star plant. And the active ingredient is semic acid. So some things in China are also good. And this was first manufactured in 1999 by Gilead Pharma, which made the blockbuster drug remdesivir. So that is certain history attached to oseltamivir. It's a pro-drug and it has to be converted into oseltamivir carboxylate. As Dr. Mahajan has already mentioned, this acts on the exit part. So the exit, the neuraminidase is blocked. So the exit from the cells and subsequently other cells are not infected and the progression and multiplication of the virus and the spread of the virus is stopped. Approved in more than 100 countries, the FDA has approved this drug in as small as 2 weeks of age. So a child more than 15 days of old also can be given oseltamivir. Of course, we have to assess the risk and the benefit. The drug dosage, Dr. Murli has already mentioned. You can remember particularly 60, 90, 120 is easy to remember. Now, the most important part we should remember is that many drugs, other drugs are available. The oral drug oseltamivir is approved for the treatment and the prophylaxis part. The other certain drugs are IV or inhalation. This thing, they are not for prophylaxis and are not available also. And the old drugs such as rimantadine, amantadine, there is lot of drug resistance. As Dr. Murli has already mentioned, again I am stressing the important part is to start the treatment within 72 hours. According to the CDC and American guidelines, clinical suspicion is very important. Depending upon the history and the clinical sign symptoms, and more so in the high risk group, we should not wait for the results to come positive or wait till the testing is done. Clinical suspicion is more than enough. In fact, there was a study in which it was found out that about 35 to 40% deaths were in children who are perfectly normal, who didn't have any comorbid conditions. And why within 72 hours, which were already mentioned, because the multiplication of the viruses takes place in the first 72 hours. So if you hit in the first 72 hours, it decreases the ultimate morbidity, the mortality, the chances of complications, the chances of landing up in pneumonias and going into respiratory failure and further progress. So it decreases the duration and the morbidity and the mortality. That is the reason we should hit early and we should hit fast. Dosages, just like to mention, is that prophylaxis below 9 months of age till now has not been approved, but the treatment part has been approved. Below 9 months of age, it is 2 milligram per kg. And if the child is a very premature baby, the dosage is 1 to 1.5 milligram per kg. And as Dr. Murli mentioned, the dosage is 5 days duration. But in some cases, such as severe immunocompromised cases, the duration can be up to 10 days. Empiric treatment, depending upon the suspicion, is strongly recommended. Lab confirmation is not necessary if you strongly suspect. And as we mentioned, negative lab test does not rule out, particularly the rapid test. Now, the prophylaxis part is very important. Prophylaxis in certain high risk group, such as where systemic diseases, neuro diseases, or certain respiratory cystic fibrosis, or severe asthma, repeated asthma on inhaler therapy. Those are metabolic diseases such as diabetes. So any chronic systemic, any cardiac conditions. The other things is in children, particularly less than 2 years of age, the spread is very rapid. So we should not wait for the labs. The other is high risk group is the pregnant females and adolescents, particularly who are on aspirin therapy. Obesity is another risk factor with BMI more than 40. and due to any reason, immunosuppression, for example, HIV or malignancy. So these are the certain age groups where chemoprophylaxis is indicated. And as has been already mentioned, the dose is half. The other is contact, if there is a household contact. So in those cases, prophylaxis will be needed. The other is institution, for example, old age homes, or during epidemics, local epidemics, or there is a severe outbreak of influenza. During that time, the prophylaxis duration is slightly longer. It can be 10 days to up to 6 weeks also. Now, regarding the side effects of oseltamivir, not much of side effects which we don't see commonly, but one or two things we should remember is the neurological issues, neuropsychiatric behavior changes. So we should be cautious, and sometimes allergic reactions such as Steven Johnson or epidermal necrolysis is a possibility but we have not seen. But in those cases, we should be careful. So in summary, proper diagnosis can and early treatment can prevent flu complications. Empiric use reduces complications, hospitalization, and antibiotic use. And oseltamivir is the current drug which is available. Thank you.
So thank you very much for elaborate discussion. Thank you, Dr. Murlidhar. Thank you, Dr. Patel, for very
Thank you.
elaborate, yes, for
Thank
very
you. Thank you.
elaborate discussion. It was wonderful,
Yes,
listening to your insights and wonderful to know about viruses and different type of viruses. I'm sure the audience must have benefited. Thank
Yeah.
all the audience who took time from their schedule and attended this. Thank you, marketing team, and thank you, sales team of IPRO for coordinating, and thanks IT team for your support. Thank you all very much. It was
Dr.
wonderful.
Murli, you want to add something?
No, very nice. In fact, you
Very
added a
nice.
lot of things
Yes.
which are regarding
Yeah,
side
we have
effects.
been using this oseltamivir in
So
OPD
many.
cases also
Yes.
for quite
Yes.
some time.
Very much.
And admitted to we would definitely use.
So many times.
But we
Absolutely.
should, that chemoprophylaxis part, I mean, we should consider and start using in those cases also.
Right.
Exactly.
Thank you very
Very
much.
nice.
Thank
Very
you.
nicely
Yes.
covered. And in fact, the side effect like nausea, vomiting, or skin rashes, which he has mentioned. Yes. Sometimes we have seen mild skin rashes, not too severe one,
Yeah, those
but of
severe
course,
reactions we have not seen, but we should be just aware.
fortunately, we should be always keen to see. And many times, he has rightly said, these rashes mimic sometimes viral rash. So we have to be cautious and clinically differentiate between these two types. Yeah.
Thank you very much.
Thank you. Thanks a lot,
Thank
Mahendra
you,
bhai.
Etro,
Thanks,
for the
yes,
Yeah.
it was
Thank you,
our
Etro.
pleasure.
opportunity.
Thanks so much of insights. Thank you. Thanks, Shashidhar. Thank you.
Thank you.
Thanks, Amrita.
Thank you.
Thanks, Murli.
Thank you, Mahendra bhai.